We will be presenting coronary artery disease by Carter Adams, Patricia Carmona, Shalise Aycock, Reed Hoffman.
The following are risk factors for CAD. Aging and menopause are associated with increased exposure to risk factors and poor endothelial healing. Family history may contribute to CAD through genetics and shared environmental exposure. If people receive appropriate preventive care and modify lifestyle choices, these factors can significantly reduce the risk for CAD. The CDC lists the pathophysiology of coronary artery disease, stating that it is caused by plaque buildup in the walls of the arteries that supply blood to the heart and other parts of the body. Plaque is made up of deposits of cholesterol and other substances in the artery. Plaque buildup causes the inside of the arteries to narrow over time, which can partially or totally block the blood flow. This process is called atherosclerosis. It impairs the pumping ability of the heart by depriving the heart muscle of bloodborne oxygen and nutrients. The earliest lesions of the continuum are those of coronary artery disease. Atherosclerosis occludes the coronary arteries. CAD can diminish the myocardial blood supply until deprivation impairs the cells and temporarily deprive of blood supply. They remain alive but cannot function normally.
CAD is thought to begin with damage or injury to the inner layer of a coronary artery, sometimes as early as childhood. The most common symptoms of CAD is angina, and this is the type of chest pain linked to heart disease. Some of the symptoms would be squeezing, heaviness, pressure, tightening of the chest, aching, and shortness of breath. The clinical manifestation in women is a little different. Pain or pressure over the chest that travels to the arm or jaw, a burning sensation in the chest or upper abdomen, or shortness of breath, irregular heartbeat, dizziness, and sweating.
Diagnostics of CAD include physical examination, which may be tachycardia, extra heart sounds, and pulmonary congestion. Signs of atherosclerosis may also be present. Bruise may be auscultated from the carotids or peripherally. Electrocardiograms are an extremely useful diagnostic tool that help detect ischemia, structural issues, and arrhythmias, which can prompt the provider for further investigation. Imaging such as CT, MRI, and ultrasound may aid in detecting atherosclerotic plaques. Radionuclide imaging or nuclear stress tests are helpful in detecting ischemia even in those asymptomatic patients. Cardiac catheterization with coronary angiography visualizes the coronary arteries and the extent of the disease. Treatments for CAD usually include lifestyle modifications, pharmacological treatments, and certain medical procedures. Lifestyle changes include smoking cessation, staying physically active, eating a low-fat, low-salt diet with plenty of fruits, vegetables, and whole grains. Various drugs can be used to treat coronary artery disease. These include cholesterol medications, aspirin, beta blockers, calcium channel blockers, ranolazine, nitroglycerin, and ACE inhibitors. Medical procedures such as cardiac catheterization or angioplasty with stent placement or coronary artery bypass surgery can also be used to treat CAD.
Hi, my name is Reed Hoffman, and I'll be presenting the case study for our pathophysiology presentation on coronary artery disease. This case study is about a 73-year-old female patient who presented with initial symptoms of angina with exertion. The patient also had inverted T waves on her abnormal EKGs. However, the patient had none of the other symptoms of tachycardia and abnormal heart sounds that you're likely to see. The patient had a history of hypertension, hypercholesterolemia, prediabetes, and previous tobacco use. The patient had, upon further workup, the patient had 90% occlusion of her right and 70% occlusion of her left coronary arteries from atherosclerosis that was shown during the angiograph. After one additional angiograph and some medical treatments, including statins to help reduce her cholesterol and a stent placed to help the blockage, the patient went home and was asymptomatic for years. After approximately 15 years, the patient returned with angina associated with moderate exertion, which was worrisome with her previous history. She had restenosis in her stent with 80 to 90% obstruction in 5 different arteries throughout her heart. The patient also had diffuse ventricular repolarization changes with elevated troponin of 0.34 and CKMB of 0.18. Soon after, the patient developed left arm pain along with new onset AFib. The patient was diagnosed with a DVT. Unfortunately, the patient was unable to recover from the pacemaker placement and died shortly afterwards in the hospital. This study shows many common traits with what is described in the text. However, there are some differences. This case study was found on the NIH website, and that seems to be about it. Thank you for watching our presentation about coronary artery disease, and have a good day.